continuing on with part 3 of Unit 8. So we'll continue talking about a positive screen and incompatible cross-match, which is obtained during routine pretransfusion testing. The positive usually indicates the presence of an alloantibody. An alloantibody is one human antibody against another human's red cell antigens. You'll want to perform a panel study, which I call a glorified antibody screen. Instead of testing against 2 or 3 reagent cells, you're going to test that patient sample against 11 additional cells. In this way, a pattern will form that most of the time will allow us to identify the antibody specificity. By knowing the antibody specificity, you'll know the likelihood of finding antigen-negative blood in your inventory. For example, an anti-Big E is very easy because 8 out of 10 units should be Big E negative. But for anti-little e, only 2% of the population is negative, so only 2 out of 100 will be negative for the little e antigen. So you'll know immediately that you're probably going to have to go to your blood provider. You must use appropriate anti-serum to verify the units are antigen negative. The exception is it's not necessary to confirm antigen negative for M, N, P1, or Lewis antigens. Now, they must be cross-match compatible, but you don't have to verify that the compatible units are antigen negative. Now, you need to meet or exceed the AABB requirements, so at your facility, maybe they do mandate that these units be phenotyped for the antigen. But in generally, for these antibody specificities, we rely on the cross-match. If multiple antibody specificities are present, you have to identify all of them, which means you may have to send your sample to a reference lab. In my practice, sickle cell patients are like super responders, and it's not unusual for them to have multiples. Antibodies to high incidence antigens, the most promising source for donor blood will be either siblings, brothers or sisters, or the AABB rare donor blood file. A high frequency antigen is one like Solano, in which less than 0.1 or 0.01% of the population will be negative. So the chances of you finding compatible blood within your inventory or within your city's inventory are very unlikely. An autocontrol is required as a part of any antibody workup. The autocontrol is testing the patient's serum against the patient's cells at all 3 phases, immediate spin, 37, and Coombs. If the autocontrol is positive, obtain a patient history. If the patient has been transfused within the last 3 months, there may be an alloantibody present, which is reacting with the transfused donor cells, which may be due to either a primary or secondary immune response. Mixed field agglutination is usually noted as only the donor cells are positive for the antigen, and then they are coated with the patient antibody. So what you'll see is as you're shaking the tube, you'll see a sea of free cells. It looks silky, it looks smooth, and then boom, these little tiny agglutinants will pop up. And if you look at it under the microscope, you can also see that they're refractal. They just look different than a regular agglutination. If the autocontrol is positive, you must perform a direct antiglobulin test, because an autocontrol is not the same thing as a direct antiglobulin test. The final state is the same, meaning we wash 3 times, we add anti-human globulin serum. But the autocontrol, you have added enhancement media, you've incubated, so it's handled differently. A direct antiglobulin test is where you take cells out of your cell suspension, put a drop in a tube, wash 3 times, and directly test it with the antiglobulin serum. No incubation, no enhancement reagent. So I want to stress this, and we'll be talking about this again, that the DAT and the autocontrol are different. If the direct antiglobulin test is positive, then an elution procedure is performed. And this procedure is used to actually remove the bound antibody from those cells so that the specificity can be identified. We will be talking about elutions in greater detail when we talk about antibody workups. Potent cold reactive antibodies may cause problems with ABO, D-typing, as well as the antibody detection and cross-match. The most common specificity is anti-big I, which may show high thermal amplitude, meaning that it is stuck so hard at your immediate spin room temperature that even after incubation, it doesn't come apart. And that's something that's called high thermal amplitude. And I had one that was so strong that at 37, it was 4+. It was 4+ at immediate spin, 4+ at 37. And at Coombs, when I was washing the cells as best as I could to break up the agglutinates, I couldn't. And so I was adding Coombs serum to a 4+ agglutinate, which of course, then my interpretation was 4+, but it was a false positive because they were already agglutinated before I added the Coombs serum. These cold reacting antibodies react with adult big I cells, but not cord cells. Remember, when you're born, you are born little I positive, and then you transition to the adult phenotype of big I. So cord cells they may have a little bit of big I, but for the most part, they are little I positive. It is very important to determine if there is a cold antibody that is masking a warm antibody. So after you identify this antibody as anti-big I, you can perform what's called the pre-warm technique, and I want you to memorize it. You have to put you label a tube and put some serum, or I just put my entire serum or plasma tube in the heat block for 10 or 15 minutes to warm it up. Then I label my 3 screen cell tubes. And again, you label at the top with the patient initials, and I put those in the heat block. And I add a drop of my screen 1, screen 2, and if you use 3 screen cells, screen 3. And it doesn't take but a few seconds really for that small volume to heat up. Then I add my pre-warmed serum to my pre-warmed cells and incubate. After incubation, I wash with warm saline. I take a clean saline bottle, I fill it with, not fill it, but maybe put a third, a fourth full of saline. I put it in the microwave for, I don't know, a minute. You have to play around with it. I used to know because I did these all the time. But you put a thermometer to verify that you haven't gotten the solution too hot, because hot saline will cause your red cells to burst. So when these tubes are in the heat block, you add the warm saline to the 3 screen cell mixtures, and then take it out of the heat block and immediately spin it down. You say, well, Terry, what about the immediate spin? What about the 37? You've already done that. We already know those are positive. Now what we're trying to do is to determine if underneath that cold auto there's a warm allo. So then as soon as you continue washing with the warm saline, add your Coombs serum, and if this is truly an anti-big I, it'll be negative. And then you don't have to do any more additional testing so far as antibody identification. For the cross-match, a cold autoabsorption may be necessary, and again, we're going to cover this later. Rouleau is a property of serum that causes all cells tested to appear agglutinated at room temperature and 37. It does not affect the AHG phase of testing, as all the serum is removed by washing prior to adding the Coombs serum. Rouleau is usually due to the presence of abnormal proteins causing the red cells to be sticky. It has a stack coin appearance, of the red cells if you look at it under the microscope. To confirm that it's rouleau and not agglutination, you perform what's called a saline replacement test. So you spin the tubes down and they were agglutinated, or they appear to be agglutinated. So the next step is to respin them and remove the serum. Then you add 1 to 3 drops of saline. I do this with a dropper. Mix it really well and respin. Rouleau formation will be dispersed by the saline. True agglutination will not. So if after you do the spin and read, and there's a special way of recording this so that you can record both immediate spin readings. So one would be 3 plus over 0, and again you would have a detailed explanation of what you did. Then you spin those tubes down, remove the saline, add more serum, the same number of drops in your enhancement, and proceed to the 37 incubation. Then you repeat the process if rouleau was identified at immediate spin, meaning you spin and read if it's agglutinated and you identified rouleau in immediate spin, then you spin it down again, remove the additive serum from the tube, add 1 to 3 drops of saline, really mix it well, and reread it. Again, if it's rouleau, the pseudo-agglutination will go away. Then you proceed on to the anti-human globulin phase of testing, which is washing 3 times and adding Coombs. Because there's no serum proteins at this stage of the testing after you wash 3 times, the anti-human globulin test, those reactions, whatever you get, are what you get. One of the rarest causes of false positives is reagent problems. So you've done your antibody screen, you've done panel studies, and again, based on the reactions that you've obtained, you start suspecting that it's something going on with your patient and the reagents involved in your reagent cells. This may be due to a variety of drugs or additives present in the reagents which cause false positive results. They put additives and they put drugs in there to maintain the viability of the cells, to preserve them. So these, and again, we're talking, in my professional life of over 35 years, I've seen one in which this was an issue. If reagent red cells are positive but the cross matches appear compatible, suspect the patient reacting with an additive in the reagent red cells. This is a simple solution. You just wash the reagent red cells and retest. If you get negative reactions, there you go. That was the problem. If all screen and cross-matched tubes are positive, suspect the patient's antibodies reacting with a substance in the enhancement media. So repeat with a different enhancement or do a saline test. So again, you don't do this type of testing or come to this conclusion unless everything else has been ruled out. Another scenario which may occur is that you have a positive screen, but the cross matches appear compatible. This may be due to the fact that the patient has an antibody directed against an antigen on the screen cell, which is absent on the donor. For example, you have an anti-big E, so it will react with the E positive cell in the screens, but your donor may be E negative, so you'll have a negative reaction. Another cause for this is that the patient may have a weak antibody reacting with homozygous screen cell, and the donor is either heterozygous or negative for the antigen. This is called dosage effect, where patients, I've seen this before, that they will only react with a stronger dose, a double dose of the antigen on the cell, and will be negative with a heterozygous or a cell that has half the amount of antigens. And in this case, the donor may, again, be heterozygous or they may lack the antigen. You must perform an antibody identification, a panel study, and then test the donors for the antigen if it's a clinically significant antibody. And you cross-match the units that are negative for the antigen. So here's an example of the presence of an alloantibody directed against screen 1. which the antigen apparently is either not present in donor 1 or donor 1 may be heterozygous and have a weaker expression, giving a false negative. So let's say that you have a negative screen, but the donor is incompatible. The most common cause of this scenario is that the donor unit has a positive DAT. And I want you to put a star by this because, again, if you have a negative screen and 1 out of 2, 1 out of 4, 1 out of 6 donors is incompatible, then that points to something being wrong with the donor unit. And so you perform the DAT on the donor, and if it's positive, you return it to the blood provider. When we used to do Coombs cross matches consistently, this was not an uncommon problem. And what does it mean that the donor has a positive DAT? Probably nothing, because they do very careful screening. Only healthy donors are selected, and sometimes during storage, nonspecific coding of donor cells can occur that will then give a false positive at the Coombs phase of testing. So that's the most common cause. Rarely, the next reason is that a patient may have an antibody to a low incidence antigen that's present on the donor cell, but it's absent from the screen cells. So you still perform the DAT on the donor unit, and if it's negative, then it points to this scenario, and you would want to perform an antibody ID. I've seen it happen just so very rarely. Anti-JSA, a very, very low frequency antigen that many times the screen cells are negative for, I actually picked up in the cross match. What if I had missed that? What if I did an immediate spin cross match and I transfused this incompatible donor? There probably would be a reaction, but the patient wouldn't die. The cells would just have a decreased rate of survival. The last thing you may want to do if you have a negative screen and an incompatible cross-match is repeat ABO grouping on the donor sample. Now, this should have been done as part of processing coming in, but perhaps the donor unit was mislabeled. So again, we have this negative screen, but the donor is 2+ incompatible at the antihemoglobin phase of testing. So the first thing you're going to do is perform a DAT on the donor. And if that's negative, then you would need to do an antibody identification by doing a panel study. Continuing on with the negative screen and incompatible cross matches. If you get agglutination at room temperature only, meaning you have agglutination at room temperature, but at 37 it's negative, at Coombs negative, the donor red cells are incompatible with the patient. So again, retype the donor to see if instead of a group O, they were labeled as group A, which would cause a 4+ agglutination with a group O person. Think about if the person is a group A, that they may have anti-A1 in their serum. So if they are an A2 or A2B person, and they have anti-A1, you will get agglutination at immediate spin with the A1 cells. So you want to go down that path of resolving an ABO incompatibility. Or you may have other alloantibodies which are reactive at room temperature only. So you want to perform an antibody ID. So again, those are causes at room temperature. If the cross-match is incompatible at the Coombs phase only, the donor RBCs may have a positive DAT. We talked about that. The antibodies reactive only with cells homozygous for a particular antigen, and maybe the screen cells don't have a homozygous cell. So in that scenario, you would perform an antibody identification. Or we talked about this already, the antibodies reactive with a low frequency antigen that's present on the donor cells, but is not present on the screen cells. So again, perform a panel study. So all the pre-transfusion testing has been done and appropriate donors have been found for this patient. So in labeling blood, a tag or label must be attached to the blood container indicating the recipient's two independent identifiers, one of which is the patient's name. The other could be a medical records number. In hospital setting, that's what we're going to use. The recipient's ABOD type must be on this label. The donor unit or pool ID, for example, cryoprecipitate, you never give one unit. Minimum is usually 6, and they're put in one bag, which is called a pool, and that pool is given a number. The donor's ABO group, and if required, their D type. The interpretation of the cross-match if performed. For example, we don't cross-match plasma, we don't cross-match platelets, so the only time you would need a cross-match is if red cells are used. The component type, whether it's platelets, red cells, plasma, and any special transfusion requirements for this particular patient. They may require CMV negative or reduced risk, irradiated, or if you have an unexpected antibody, that proof documentation that this is antigen negative. Prior to issuing blood components for transfusion, personnel in the blood bank must check the expiration date of the blood component to avoid issuing an outdated component and inspect the unit for abnormal appearance. For example, in a red cell unit, I'm going to check it for clots or hemolysis at the sprig closest to the donor unit. And a platelet, I'm going to look for clumping of the platelets. The person picking up the blood component must have documentation showing the identity of the patient they're picking up blood for. This way I have some assurance that they're picking up the proper component for the proper patient and that they're not going to take this unit of blood and go transfuse it to a totally different patient. The transfusion service must document the name of the individual issuing the blood. In these computerized times, I'll have a code that I put in, the date and time of issue, because once these components leave the transfusion service, if the patient blows an IV, for example, they can return it within a finite period of time. Usually it's 30 minutes. The name of the person to whom the blood was issued. Some transfusion services will perform a complete review of the component label, and with years of experience, it would take me less than a couple of minutes. So we cover the ABO type, the cross-match results, any special requirements. So all of that is covered in a matter of minutes to make sure that both of us know that this product is compatible with this recipient. And maybe I dreamed it, but there is a machine that is being developed to issue blood products, because in a busy transfusion service, this takes up a lot of time because a lot of the stuff that we cross-match is actually transfused. And so I was trying to find a picture of it, but I couldn't. But it was so cool. They have to come up with a specific identification criteria for the patient. It's put into this machine that just then, like a vending machine, it will deliver the component, and no transfusion service personnel are involved. A process must exist to confirm that all of the following are in agreement: the patient identifying information, the request. Blood can only be ordered through a prescription offered by the doctor, and the fact that we have the components ready indicates that we have received the request. The blood or components that they're picking up, I can't tell you the number of times the nurse has come down and I just have red cells ready and she's wanting plasma, so that they know what component they're picking up. And then records. Every step in the process, records are maintained in compliance with federal law. All discrepancies must be resolved before the issue. Final identification of the recipient prior to transfusion rests with the transfusionist, the person who is actually going to give the component. They must identify the patient and the donor unit and certify that identifying forms, tags, and labels are in agreement. And I should write a book. I have so many stories to tell, and this is a true story. At institutions nationwide now, they require 2 people to go in the room and corroborate the information on the donor unit with the patient's armband. Well, these 2 nurses must have done it in the hallway because the nurse went and transfused this product to the wrong patient. Thank goodness they were ABO compatible, but rules are not meant to be broken. I know nurses are very busy. My heart goes out to them. But a transfusion of an ABO incompatible unit can kill a person. So you can do everything right, and unfortunately somebody who doesn't have ethics will do the wrong thing, and because of that, a patient may die. Release of blood in urgent situations. There are times that the patient condition warrants the release of uncross-matched blood. The physician must weigh the desperate need for blood against the hazard of transfusing uncross-matched blood. If blood is released before cross-match is completed, a form must be signed by the physician indicating the reason for transfusing uncross-matched blood. And sometimes this is done after the fact. If a patient's bleeding to death, I'm not going to wait for a form in order to release this blood for this urgent need. We can get all the paperwork done after the fact. This does not absolve the transfusion service from the responsibility to issue properly labeled donor blood of an ABO compatible group. Again, what is the universal donor for red cells? O negative. What is the universal donor for plasma? It's AB. So we have to make sure that we issue ABO appropriate components for the situation. Compatibility testing must be started as soon as the sample reaches the transfusion service. And at my institution, we trade. Here's your uncross-matched blood, and they hand me the tube of blood for the cross-match. Because once they start transfusing that blood into the patient, we now have however many donor units are in there plus the patient, and that can muddy the waters when it comes to compatibility testing. Communication is very important in these types of situations, so you want to immediately begin compatibility testing. Even before I'll ask, hey, if you can get me the sample, if I can at least do an ABOD type, I can at least give ABOD compatible blood instead of giving O-neg, which is a very precious resource for us. It only takes a few minutes to do an ABOD type. That's why during labs, I don't want you to rush, but you need to work on labeling your tubes faster, dropping your reagents faster, because we can't decrease the amount of time or tubes for anything, but your processes, how you do things, can decrease the amount of time. You cannot rely on previous records. So you have this requisition. It has the same medical records number and name as the person in your system who is an AB-pos. You cannot give out AB-pos blood. You cannot rely on previous records. What if the patient had a bone marrow transplant and now instead of being an AB-pos, they're an O-neg? If the ABOD type is unknown for red cells, you release O-negative red cells. The label on this unit of blood that you're issuing uncross-matched must indicate in a conspicuous fashion that the blood is uncross-matched. And depending upon where you work, you're going to have these red labels. Red attracts attention. Red means danger. It'll say uncross-matched blood. And if you have a computer printer, you can generate a label very quickly. Or in some conditions, we just have to hand it out. We don't know the patient's name or their ID number, so we just slap the uncross-matched blood label on it, and we send it on its way. Begin compatibility testing promptly, meaning stat. You drop everything you're doing. Yeah, you're going to have to start those tests over. So what? This patient's bleeding to death. So you drop whatever you're doing, and you start working on this patient. If an incompatibility is detected at any stage of testing, notify the patient's physician and the transfusion service physician or your supervisor immediately so they can make the call whether to stop this transfusion, or if the bleeding is out of control, they may wish to continue with this until you can find compatible blood. So we discussed release of blood in urgent situations. The patient is bleeding, and we need a couple of units until you can start getting us cross-match compatible blood. Massive transfusion, there's several different definitions. In fact, I went out on my listserv to get what their definitions and their protocols are. One is infusion of 8 to 10 units within 24 hours, or a blood volume exceeding the recipient's total blood volume. Another definition is transfusion of 4 to 5 RBC units in 1 hour. And another is exchange transfusion. That is a separate topic that we'll discuss later on. I keep putting this carrot in front of you, saying, okay, we're going to talk about this later. But these are definitions of massive transfusion. And basically, we're replacing the patient's blood volume with donor blood. This may occur due to unexpected surgical or medical emergencies, planned circumstances in cardiac or vascular surgery, an exchange transfusion where we're going to replace the patient's blood, the entire blood volume, with donor blood, or it could be due to trauma. If a patient has been massively transfused, there's such a small volume of patient's blood remaining that complete cross-matching has limited benefit. Why? Because the pre-transfusion sample no longer represents the currently circulating blood. We probably have 8 or 10 units of red cells or 4 to 6 units of plasma. The composition of the blood is no longer what was present in the pre-transfusion sample. So once the patient's massively transfused, it's only important to confirm ABO compatibility of donors. So you had a couple drops of, you follow your protocol, serum plus donor cells, mix, spin, and no agglutination indicates ABO compatibility. If it was ABO incompatible, there would be 4+. And computer cross-match. If you have a system that has been validated to do cross-match, computer cross-matching, then the computer will find your donors for you. If an unexpected alloantibody is present, abbreviating the cross-match is still acceptable so long as the units are antigen negative and ABO compatible. All hospitals, especially the large hospitals, adopt a massive transfusion protocol. And studies have been done to document that in addition to red cells, transfusion of other components during this time are equally critical. They must take into consideration dilutional coagulopathy. Giving red cells plus IV solutions will not replace clotting factors or platelets. So a trauma protocol for massively bleeding patients may involve issuing all of this at the same time, 4 units of group O negative cells, 4 AB fresh frozen plasmas thawed, and 1 AB platelet. And they'll repeat this until the bleeding is controlled. Some institutions are even going to a place that I'm not real comfortable with yet, and they will give out low titer group O positive whole blood, group O positive red cells, and group A plasma. And you say, oh my gosh, what? Because the O cells are compatible, but the O plasma's not. But they deem that a certain titer of antibodies in a group O person will theoretically not harm the recipient red cells. And so far as the group O positive red cells, we really want to preserve our D negatives for those people who require them. And when you're thinking about a massive transfusion, what you're doing is you're dumping in all these components and they're coming out. One supervisor I spoke with said, Terry, the chances of these individuals surviving the trauma are slim to none. And even if they do survive the trauma, they have been exposed to massive quantities of foreign red cell antigens. Their immune system is going to go into paralysis. They will not, and they've done several studies after the fact of how many of these individuals produce anti-D if they were D negative, and it's very, very, very few. And group A plasma, so that, again, the chances of this causing harm, group A plasma has anti-B. So the only person that may be affected would be if you had a B or an AB person, which, again, I'm not totally comfortable with this. I understand it because massively bleeding, you're probably not going to survive. If you survive, you're going to be in immune paralysis where you're not going to recognize these foreign antigens as foreign. The bleeding has stopped when, what do you do after non-group specific transfusion? Switch ASAP to their own blood group to minimize the transfusion of ABO antibodies. Because after you transfuse about 10, 15, 20 units of red cells, the plasma then does become a factor. The sample should be provided when the uncross-matched blood is picked up, and then you want to type that sample stat and then provide ABO identical for future transfusions. Massive transfusions with group O may cause passively acquired anti-A or anti-B to cause problems, which require transfusing blood that lacks the ABO antibodies. So what that means, passively acquired. This person isn't making, I'm a group A, I'm not making the anti-B. I got the anti-B passively through transfusions of all these group O blood units. For the D type, you want to switch immediately. If D negative, continue if at all possible. But again, you don't want to deplete your entire D negative stock, because I would rather continue with D positive for this person and then provide D negative for these other 10 patients. So you have to use common sense. And if there's any question as to the true D type, then you'll transfuse D negative. This is the end of Unit 8. Sorry this one took so long, but I just have so much information to share with you.